is Max Melman. I am the co-director of the Law Medicine Center here at Case Western Reserve University School of Law. My co-director, Professor Hoffman, is here. So it's my pleasure to welcome you to the 2021-22 Schroeder Lecture. The lecture is named for Oliver C. Schroeder, Jr., who, did I just do something? Ollie joined the faculty in what was then the Western Reserve School of Law in 1948. And in 1953, he co-founded the Law Medicine Center, which was the first health law program in the country. And he retired in 1986, and the Schroeder Lectureship was endowed in his honor upon his retirement. And by the terms of the charter of the lecture, the Schroeder Lecturer is selected on the basis of, quote, scholarly distinction and contribution in the arenas of health policy and law. Our 2021-2022 Schroeder Lecturer is Dr. Michael Carome. Dr. Carome grew up in Cleveland Heights. He received his undergraduate degree from Georgetown University, his MD from Case Western Reserve University School of Medicine. Let's see, following medical school, he completed fellowships in internal medicine and nephrology at Walter Reed Army Medical Center in Washington, D.C. Dr. Carome has served as Associate Director for Regulatory Affairs at the HHS Office of Human Research Protections. He's also served as Director of that office's Division of Compliance Oversight. He's been an Assistant Professor of Medicine in the Department of Medicine at the Uniformed Services University of Health Sciences, and a captain in the Commission Corps of the U.S. Public Health Service. From 1992 to 2010, Dr. Carome was staff nephrologist at Walter Reed. In 2011, he became the Deputy Director of the Health Research Group, the public interest healthcare advocacy branch of Public Citizen, which was founded by Ralph Nader back in 1971. In 2013, Dr. Carome took over as Director of the Health Research Group from Dr. Sidney Wolfe, another graduate of our medical school, and, as it happens, a former Schroeder lecturer. Dr. Carome's lecture today is entitled FDA Approval of Aducanumab for Alzheimer's disease, emblematic of regulatory capture corrupting the agency's review and approval of new drugs. Please note that CLE credit is available for this session. At the end, we'll post a slide with more information, and our Director for Academic Centers, Patty Harbold, who's outside, will be posting the link to the CLE form on chat for those viewing the session remotely. So now please join me in welcoming Dr. Michael Carome.
Well, good afternoon, and thank you for that very kind introduction. I'm honored to give this year's Oliver C. Schroeder, Jr. Scholar in Residence Lecture. For 50 years, Public Citizen's Health Research Group, which was founded by my colleague, Dr. Sidney Wolfe, has engaged in independent, research-based advocacy targeting the FDA and the pharmaceutical industry. In testimony before hundreds of FDA advisory committee meetings, we have opposed approval of numerous new drugs because, in our judgment, their risk-benefit profile was unfavorable. Through citizen petitions at the FDA, we have sought the removal of more than 40 drugs from the market because they were too dangerous, and the addition of stronger warnings to the labeling of several dozen other drugs, and in many cases, the agency granted our petitions. Today, I would like to tell you the story of drug maker Biogen's development of Aducanumab for treatment of Alzheimer's disease, the FDA's unprecedented, inappropriately close collaboration with the company before and after submission of its biologic license application, or BLA, for the drug, and the agency's subsequent approval of the drug under the accelerated approval pathway. I will describe our group's advocacy campaign over the past year opposing FDA approval of Aducanumab and seeking to hold the agency accountable for its inappropriately close collaboration with Biogen and then its reckless decision to approve the drug, one of the worst decisions in the agency's history. I will present events regarding the development and review of Aducanumab as they became publicly known. I will conclude with some reflections on how the FDA reached this point, this new low point, as a regulatory drug agency. Just some background on the drug. Aducanumab is a recombinant human monoclonal antibody targeting amyloid beta. The drug was developed primarily by Biogen in partnership with Eisai as a treatment for Alzheimer's. Like the prior 22 unsuccessful experimental drugs targeting amyloid beta that were pursued as potential treatments for amyloid over the past 2 decades, use of aducanumab is predicated on the still unproven amyloid hypothesis, which was introduced in the early 1990s and posits that deposition of amyloid beta in the brain of patients with the disease causes neurodegeneration of that disease. After completing 2 phase 1 trials of aducanumab, studies 101 and study 103, Biogen in 2015 launched 2 identical phase 3 randomized placebo-controlled clinical trials to evaluate the safety and efficacy of 2 dosing regimens of aducanumab. Study 301, also called ENGAGE, and study 302, also called EMERGE. By early 2019, each study had enrolled approximately 1,650 subjects with mild cognitive impairment due to Alzheimer's disease or mild Alzheimer's dementia. On March 21, 2019, Biogen and its partner Eisai announced the decision to terminate both pivotal phase 3 trials after a pre-specified interim futility analysis by an independent data monitoring committee indicated that the trials were unlikely to meet their primary efficacy outcome upon completion. That action should have marked the end of aducanumab as a treatment or potential treatment for Alzheimer's disease, at least as it pertained to the studies thus far completed. But on October 22nd, 2019, Biogen shocked the medical community when it announced in another press release plans to seek FDA approval for aducanumab based on a series of post-hoc analyses of studies 301 and 302, including additional data that have been collected after the announced termination of the studies. The company stated in a press release that new analyses have been, quote, conducted by Biogen in consultation with the FDA. On December 5th, 2019, Biogen presented top-line results of studies 301 and 302 at a scientific conference. The post-hoc analyses conducted by Biogen in collaboration with the FDA showed that study 301, at both the low and high dosing regimens, the drug was not effective, did not show any improvement in the primary efficacy endpoint. Whereas in study 302, the drug at only the high dose regimen resulted in a small, statistically significant, but not clinically meaningful improvement in the primary efficacy endpoint. In a July 8, 2020 press release publicizing the completion of its BLA submission for aducanumab to the FDA, Biogen noted that the submission followed ongoing collaboration with the agency. On November 4, 2020, the FDA posted on its website a briefing document for the agency's Peripheral and Central Nervous System, or PCNS, Drugs Advisory Committee that was to meet on November 6th. Disturbingly, the primary briefing document for the advisory committee meeting had been written jointly by the FDA and Biogen, with most of the content apparently written by the company. In our experience attending or participating in hundreds of FDA advisory committee meetings over decades, we could not recall ever seeing an advisory committee meeting briefing document that was explicitly written jointly by the FDA and the sponsor of the product to be considered by the committee. The Joint Advisory Committee briefing document revealed further details of the close collaboration that had occurred between the FDA and Biogen following the company's March 2019 decision to terminate the phase 3 clinical trials. For example, the briefing document stated that Biogen had a June 2019 meeting with the FDA that included a discussion of post-hoc analyses of data from study 302 conducted after its termination, showing apparently positive results. According to Biogen, the FDA stated the following at this meeting, quote, it is imperative that extensive resources be brought to bear on achieving a maximum understanding of the existing data. Given the wholly unique situation that is the current state of aducanumab development program, those further analyses would best be conducted as part of a bilateral effort involving the agency and sponsor, i.e. through a work stream or working group collaboration. Of note, details regarding the extent of this FDA-Biogen collaboration would not become known until after the FDA approved the drug in June. Typically, sponsors conduct their own statistical analyses of clinical trial data supporting new drug applications, or NDAs, or BLAs, and the FDA then conducts its own independent analyses of that same data following submission of their applications for approval. Such appropriate separation between the clinical trial analyses conducted by the sponsor and those conducted by the FDA is critical to maintaining the independence and integrity of FDA's review of the data. In the case of aducanumab, the close collaboration between the FDA and Biogen in the post-hoc analyses of clinical trial data and the subsequent joint authorship of the primary briefing document for the November 6, 2020 advisory committee meeting resulted in a one-sided consensus briefing document. That document overwhelmingly emphasized the post-hoc analyses that yield positive results, suggesting the high dose was effective for Alzheimer's, primarily the analyses of study 302, but significantly downplayed the results of the post-hoc analyses of the other trial showing the drug was not effective, study 301. The FDA characterized the results of study 302 as being highly persuasive, strongly positive, and capable of providing primary contribution to demonstration of substantial effectiveness of aducanumab, while simply acknowledging that study 301 was just, quote, a negative study. Note that the FDA's standards for approving new drugs include, quote, substantial evidence of effectiveness, end quote, which generally requires demonstration of effectiveness in 2 well-designed, completed, randomized phase 3 clinical trials, particularly for drugs used to treat common diseases like Alzheimer's disease. Relying on dubious statistical gymnastics, Biogen and the FDA, in their joint review document, sought to discount the discordance between the negative results of study 301 and the partially positive results of study 302, and portray the post-hoc analyses of study 302 data, with supporting evidence from one of the small phase 1 studies, which wasn't even intended to evaluate efficacy, as representing the true picture of aducanumab's effectiveness in treating Alzheimer's. This cherry-picking approach was neither statistically nor scientifically appropriate. Appended to the Joint Advisory Committee briefing document was a draft statistical review written by FDA statistician Tristan Massey that highlighted numerous serious flaws in the post-hoc analyses of studies 301, 302, and the phase 1 study 103 that had been conducted by Biogen in collaboration with other FDA staff. Dr. Massey made the following conclusions. The totality of the data does not seem to provide sufficient evidence to support the efficacy of the high dose. There is much inconsistency and no replication. There is only one positive study at best, and a second study which directly conflicts with the positive study. Importantly, both studies were not fully completed and had sporadic unblinding for dose management ARIA cases, which was much higher in the aducanumab group. There is no convincing evidence of delaying clinical progression. Unsurprisingly, the pre-recorded and live presentations by Biogen and all FDA reviewers, except FDA statistician Massey, for the advisory committee meeting, were completely concordant with the one-sided joint briefing document. Dr. Billy Dunn, director of the Office of Neuroscience in the Center for Drug Evaluation and Research, or CDER, whose office is responsible for reviewing Alzheimer's disease drugs, gave the FDA summary presentation at the meeting. The language he used, as reflected in the following representative excerpts, made him sound more like a consultant hired by Biogen to endorse the company's BLA for aducanumab than like an independent, objective federal regulator paid by the American taxpayers. Quote, he said, "The effect of aducanumab in study 302 is robust and exceptionally persuasive. When considered on its own, study 302 would appear to be a home run." During the meeting, advisory committee members unleashed a torrent of appropriately harsh criticism of the post hoc analyses of studies 301, 302, and 103, the nature and organization of the questions posed by the FDA, and the one-sided joint briefing document. For example, Dr. Scott Emerson, Professor Emeritus of Biostatistics at the University of Washington, Seattle, said the following: "This analysis seems to be subject to the Texas sharpshooter fallacy, a name for the joke of someone first firing a shotgun at a barn and then pinning a target around the bullet holes." Likewise, Dr. Caleb Alexander, Professor of Epidemiology and Medicine at Johns Hopkins, said the following: "I find the materials that the FDA has provided strikingly incongruent, and I have a very hard time understanding how the FDA conclude that there is substantial evidence of effectiveness, and in particular, that study 302 provides a robust and exceptionally persuasive study. And it just feels to me like the audio and the video on the TV are out of sync. There are literally a dozen different red threads that suggest concerns about the consistency of the evidence." Our advocacy opposing FDA approval of aducanumab began on November 5, 2020, with a press statement previewing our testimony before the advisory committee meeting the following day. That statement noted the following: "The overall tenor of the FDA's briefing document for the meeting reveals that the agency is actively working hand in hand with Biogen to rush to market an unproven biologic drug to treat Alzheimer's disease that could bankrupt our healthcare system." In our testimony before the advisory committee on November 6, we urged the committee to recommend that FDA not approve aducanumab for Alzheimer's disease. We argued that the post hoc analyses of the phase 3 clinical trials had been highly susceptible to bias, had not provided substantial evidence of effectiveness, and should only have been used to generate hypotheses for possible future pre-approval trials. We highlighted the FDA statistical reviewer statements in his pre-recorded presentation that, quote, "If we select only the better study, our efficacy estimate is very likely biased, and we already know not consistently repeatable. Thus, excluding data from a large trial without sufficient justification is unscientific, statistically inappropriate, and misleading." We concluded that the FDA must demand another large pre-market randomized placebo-controlled trial of aducanumab, and that FDA approval of the drug, absent substantial evidence of efficacy, would further damage the agency's already diminished credibility. On the key voting question posed to the advisory committee, shown here, asking whether it was reasonable to consider study 302 as primary evidence of effectiveness of aducanumab for treatment of Alzheimer's disease, the vote was 0 yes, 10 no, and 1 uncertain, formally indicating near unanimous opposition to FDA approval of aducanumab based on the available clinical trial data, opposition that was readily apparent throughout the entire meeting. Following the meeting, we were hopeful that the advisory committee's overwhelmingly negative assessment of aducanumab would be the death knell for Biogen's BLA. At that same time, we also concluded that there must be an independent investigation of the unprecedented close collaboration that had occurred between the FDA and Biogen before and after submission of the company's BLA for the drug. Therefore, on December 9, 2020, we submitted a formal complaint to the Department of Health and Human Services, or HHS, Office of Inspector General, OIG, calling for such an investigation. Citing the aforementioned details of the FDA-Biogen collaboration, we asserted that this collaboration dangerously compromised the independence and objectivity of senior staff and clinical reviewers in CDER's Office of Neuroscience during the agency's review of Biogen's BLA for aducanumab and key data from the clinical trials of the drug. which resulted in FDA's unbridled enthusiasm for the drug. We particularly noted that Office of Neuroscience Director Dunn likely played a key role in the close FDA-Biogen collaboration. We also argued that FDA's close collaboration with Biogen was indicative of regulatory capture at the agency, which has resulted in the agency acting in the best interest of pharmaceutical companies rather than the public interest. We listed for the OIG 3 major adverse consequences if the FDA were to approve aducanumab. First, approving the drug that has not been shown to be effective will provide false hope to millions of desperate patients and their families. Second, because the drug would be exorbitantly priced and used by potentially millions of patients for years, it would have a massive impact on healthcare economics and potentially bankrupt the Medicare program, as well as many patients and their families because of the copays. Third, the premature approval of aducanumab could impede the development of other experimental treatments for Alzheimer's disease for many years, potentially delaying progress on drugs that actually may turn out to be helpful. Also on December 9th, we sent a separate letter to then FDA Commissioner Stephen Hahn and then acting CDER Director, now CDER Director, Patrizia Cavazzoni, transmitting a copy of our letter to the HHS OIG and urging them to begin restoring public confidence in their agency and in its review of aducanumab by taking the following actions. First, endorse our call for an OIG investigation. Second, assign all further review and decision-making related to the BLA for aducanumab to CDER staff who were not involved in the close collaborations with Biogen. Third, given that he supervised the FDA team reviewing the BLA for aducanumab and likely played a key role in this collaboration, temporarily remove Dr. Dunn from his position as Office of Neuroscience Director until the requested OIG investigation has been completed. And lastly, assess whether any similar close collaborations have occurred with other sponsors that submitted NDAs or BLAs to the FDA, and if so, determine the extent to which the integrity of its review of those NDAs or BLAs have been compromised. We acknowledged in our letter to the FDA our understanding that it was not unusual for agency staff to meet with sponsors and provide advice regarding the development of drugs and biologics, the design of clinical trials, and statistical analyses of trial data, among other things. We therefore recommended that given the potential for these interactions to drift towards collaborations with a sponsor that could undermine the integrity of the staff reviewing them, has occurred in the case of aducanumab, the FDA in such cases should designate other staff who were not involved in such interactions prior to the submission of an NDA or BLA to review and make decisions on any subsequent related marketing application. We further recommended that to ensure the integrity of these reviews and decisions, a firewall be created between the FDA staff involved in any pre-submission interactions and those involved in post-submission NDA or BLA review and decision-making. And we again urge the agency not to approve aducanumab. The OIG, on January 11th, responded to us with a short pro forma letter stating in part the following. Safeguarding public health is one of the department's top management and performance challenges, and the OIG has responded by focusing on work that identifies opportunities to, among other things, ensure the integrity of review and decision-making by the agencies. OIG continuously engages in work planning and will include the collaboration issues you have raised in our ongoing work planning discussions. This initial response fell far short of committing to the type of OIG investigation that we had sought. On January 28th, we sent Dr. Janet Woodcock, shortly after her appointment as acting FDA commissioner, a letter identical to our December 9 missives to Drs. Hahn and Cavazzoni. On February 11th, Dr. Woodcock responded in writing with a full-throated defense of the FDA's interactions with pharmaceutical companies during the drug development process. She extolled the benefits of these interactions and ignored the potential downsides as became apparent in her agency's review of aducanumab. On January 29, Biogen and Eisai unexpectedly announced that the FDA had extended the review period for the company's marketing application for aducanumab by 3 months, from March 7 to June 7, after the agency had requested more data on the drug. Worried that the FDA was searching for a way to approve aducanumab following the strong opposition to approval from the advisory committee, we promptly issued a press statement reiterating our position that the FDA should reject the application for aducanumab and demand that Biogen conduct another large placebo-controlled trial before giving further consideration to approving the drug. Of note, through press releases and persistent media outreach during our advocacy campaign, we were able to partially frame the public debate regarding whether aducanumab should be approved by the FDA based on the available data, and to bring public attention to our concerns that the integrity of the FDA's review of the drug had been compromised by the agency's inappropriately close collaboration with Biogen. Here is a sampling of some of the media reports that cited our work. We also wrote a letter to Secretary of Health and Human Services, Javier Becerra, on April 1, 2 weeks after he had been confirmed by the Senate, urging him to ask his department's OIG to immediately investigate the FDA-Biogen collaboration and warning that approval of aducanumab for treatment of Alzheimer's disease, based on the available evidence, which was lacking, would pose an unacceptable threat to the financial health of the Medicare program. We noted that, given the gravity of our concerns, more definitive, prompter action by the OIG and HHS must be taken. Disappointingly, we were unsuccessful in stopping FDA approval of aducanumab. On June 7, the agency announced its decision to approve the drug under the brand name Aduhelm to treat patients with Alzheimer's disease using the accelerated approval pathway. The agency claimed that the reduction in amyloid beta plaques in the brains of subjects who participated in the clinical trials, a surrogate endpoint, was, quote, reasonably likely to result in clinical benefit. The FDA mandated that Biogen complete a post-marketing randomized placebo-controlled trial of the drug, but not until within 9 years. We immediately shifted our advocacy work to holding the FDA accountable for its reckless decision to approve aducanumab. Shortly after the FDA announcement, we released a press statement condemning the agency for its decision and noting that it showed a stunning disregard for science and eviscerated the agency's standard for approving new drugs, and that because of this reckless action, the agency's credibility had been irreparably damaged. The FDA decision to approve aducanumab, combined with Biogen's announced price of $56,000 for 1 year treatment course of the drug, sparked fierce backlash from many neurologists, academics, other physicians, and Congress, among others, and prompted 3 members of the agency's PCNS Drugs Advisory Committee to resign. Many health insurers refused to cover the drug, and some healthcare systems, including the Cleveland Clinic, announced that they would not provide drug to their patients. On June 16, we again wrote to HHS Secretary Becerra and urged him to request the resignations or seek the removal of the 3 officials most responsible for the agency's indefensible decision to approve aducanumab for treatment of Alzheimer's disease: Acting FDA Commissioner Woodcock, CDER Director Cavazzoni, and CDER's Office of Neuroscience Director Dunn. In our letter, we emphasize that the currently available evidence, including evidence from the clinical trials of aducanumab, failed to show a meaningful correlation between changes in brain beta amyloid and changes in clinical measures of cognitive function. We highlighted the fact that during the November 6, 2020 Advisory Committee meeting, in response to questions from one committee member about the lack of correlation between the observed changes in beta amyloid and in cognitive function measures, Dr. Dunn explicitly stated that the agency was, quote, not using amyloid as a surrogate endpoint for efficacy. Finally, in our letter to Secretary Becerra, we expressed dismay that the agency had approved the drug for anyone with Alzheimer's disease, despite the fact that the phase 3 clinical trials had been limited to patients with no more than mild Alzheimer's, and thus there was a complete absence of any evidence that the drug was safe or effective for patients with moderate or severe Alzheimer's. On June 25, the chairs of the U.S. House of Representatives Committee on Energy and Commerce and Committee on Oversight and Reform announced a joint investigation of the FDA's review and approval of aducanumab. Shortly thereafter, we met with staff from the committees to share our concerns regarding the FDA-Biogen collaboration before and after the company submitted its marketing application for the drug. Then on June 29, the online media outlet Stat published a detailed expose that provided stunning new disclosures about the extent to which key FDA staff and CDER's Office of Neuroscience collaborated with Biogen after the company terminated the phase 3 clinical trials of aducanumab back in March of 2019. Among the most troubling disclosures in the Stat article were the following. In early May 2019, shortly after Biogen and Eisai had announced the decision to terminate the pivotal phase 3 trials testing aducanumab and to end development of the drug, Biogen chief scientist Al Sandrock reached out to CDER's Office of Neuroscience Director Dr. Dunn, with whom Sandrock already had a long-standing professional relationship, and sat down with him for an off-the-books meeting while the two were attending a neurology conference in Philadelphia. Sandrock wanted to let Dunn know that Aduhelm, publicly declared ineffective, might actually be slowing the progression of Alzheimer's, and wanted to know if Dunn would be open to helping find a way to get the drug approved. One former Biogen employee told Stat it was clear that Billy Dunn was an ally, so the job for Biogen became figuring out how to support his efforts within the FDA. Following Sandrock's meeting with Dunn, Biogen mounted a secret campaign codenamed Project Onyx to resurrect the drug and convince the FDA to give it the green light. Central to their mission was an inside ally, Billy Dunn, the agency's top regulator of Alzheimer's drugs. FDA support grew quickly. By June 2019, only a month after the crucial meeting with Dunn, agency officials in his Office of Neuroscience were so willing to advance Aduhelm that they proposed as one option a regulatory shortcut called accelerated approval, according to meeting minutes read by the staff. The move stunned even Biogen's top executives, who had considered that pathway out of the question for a host of reasons. Finally, after the June 14, 2019 meeting between Biogen and the FDA, Biogen and the FDA established a working group collaboration consisting of company employees and agency review staff. The group met or communicated almost daily in June, July, and August of 2019, working to collect and analyze Aduhelm data for inclusion in the planned marketing submission. The group decided to pursue a standard FDA approval based on data on how patients had fared on cognitive measures. The following day, June 30th, we sent follow-up letters to the HHS OIG renewing our request for independent investigation of the unprecedented FDA-Biogen collaboration, and to HHS Secretary Becerra, again calling for the resignation of Dr. Janet Woodcock and other senior officials. Both letters asserted that the circumstances described in the Stat expose, if confirmed, painted a damning picture of FDA drug regulators who had surrendered their independence and objectivity, essentially began working on behalf of Biogen, and fostered regulatory capture of the agency. On July 9, Dr. Woodcock surprisingly announced via Twitter that she had asked the HHS Acting Inspector General, or IG, to independently review the interactions between Biogen and the FDA during the process that led to the decision to approve aducanumab for treating Alzheimer's. we responded that same day with a press statement welcoming Dr. Woodcock's belated request for an independent IG investigation of her agency's inappropriately close collaboration with Biogen. And we urged, as we had urged her to do nearly 6 months earlier, and we noted that the requested OIG investigation must examine the role that Dr. Woodcock herself played in the matter. On August 4, the HHS OIG finally announced that in response to concerns raised about the FDA's process for reviewing and approving Aducanumab, including, quote, allegations of an inappropriately close relationship between the FDA and industry, end quote, the OIG would review and assess how the FDA implemented the accelerated approval pathway for this drug and a sample of other drugs. The review will include an examination of the interactions between the FDA and, quote, outside parties, i.e. Biogen and other drug company employees, during the review and approval process for these drugs. This was exactly the type of investigation that we had requested in our original December 9, 2020 letter to the OIG. The OIG expects to issue one or more reports about this matter in 2023. So some concluding remarks. The FDA-Biogen collaboration regarding Aducanumab and the agency's subsequent decision to approve the drug under the accelerated approval pathway exemplify the regulatory capture at the agency by the pharmaceutical industry. So how did we reach this point? The origins of the FDA's decline as a pharmaceutical industry regulator date back to 1992, when Congress first passed the Prescription Drug User Fee Act, or PDUFA. PDUFA was intended to expedite the drug review process by providing the FDA with a new funding stream to hire additional medical officers and other staff to review NDAs. But in exchange for this industry funding, which across all FDA user fee programs totaled nearly $1.2 billion in fiscal year 2020 for review and oversight of human drugs, Congress required that the FDA meet benchmarks for timeliness of review and final decision-making for drug marketing applications. In addition, each 5-year reauthorization of PDUFA has provided an opportunity for drug companies and their well-paid advocates to lobby Congress for additional legislative provisions that have nothing to do with the user fees, but instead weaken the standards for approving new drugs. For example, PDUFA's first reauthorization in 1997 provided the vehicle for passage of the Food and Drug Administration Modernization Act, which permitted drug approval based on a single phase 3 clinical trial instead of the usual 2, created the Fast Track program for facilitating the development and expediting the review of drugs for treatment of serious or life-threatening diseases, and established the use of surrogate endpoints in clinical trials, among other things. Concerns about declining FDA standards for drug approvals were raised by some FDA staff following PDUFA's initial enactment and subsequent reauthorization. For example, in a 1998 anonymous survey study of FDA medical officers conducted by our group, among the 53 medical officers who responded to the survey, out of 172 officers who had been sent surveys, 17 described the then current standards for review of drugs, safety and efficacy as being lower or much lower than those prior to 1995. And 34 stated that there was somewhat greater or much greater pressure to approve a greater proportion of drugs than there was before 1995. Likewise, in 2003, HHS OIG issued a report that found that among 136 CDER reviewers surveyed, 36%, more than a third, were not confident in FDA decisions regarding the safety of a drug. Most importantly, the introduction of user fees gradually resulted in a fundamental shift in the relationship between the FDA and regulated pharmaceutical companies, such that the agency came to view drug companies as partners rather than regulated entities. FDA leaders for several years now have been transparent about the agency's partnership with industry. For example, back in 2014, Margaret Hamburg, then FDA Commissioner Margaret Hamburg, said in a speech to drug company executives, there was a new era-ship of partnership with the biopharmaceutical industry. Now, partnerships involve close collaborations between two or more entities seeking to advance shared interests and objectives. But the dynamics of a partnership are incompatible with the relationship that should exist between a regulatory agency and regulated industry. The pharmaceutical industry's primary interest is to maximize profit selling drugs, which can conflict with what should be the FDA's primary interest, protecting public health. In 1998, ProPublica published an expose describing the deeply entrenched industry-friendly culture within the FDA. ProPublica reported that according to former agency employees, as the FDA became more reliant on industry user fees to pay for drug reviews, it showed an increasing inclination to approve new drugs to please pharmaceutical companies. For example, one FDA medical team leader, former FDA medical team leader, told ProPublica, quote, "You don't get promoted at the FDA unless you're pro-industry." As we told the HHS OIG in a July 9 follow-up letter, during Dr. Woodcock's leadership at CEDAR over the past 3 decades, the relationship between the FDA and the pharmaceutical industry grew ever cozier, resulting in regulatory capture on the part of the agency. Dr. Woodcock undoubtedly helped foster the current culture at CEDAR that permitted and encouraged the type of inappropriately close collaboration that had occurred between the FDA and Biogen during the agency's review of Aducanumab. Thus, the OIG must examine her role in this matter. I close with this apropos cartoon summing up the current state of the FDA and its relationship with the pharmaceutical industry and the potential resulting harm to patients. That was posted on Twitter in response to Dr. Woodcock's July 9th tweet calling for an OIG investigation of the agency's review and approval of Aducanumab. All of our work regarding Aducanumab can be found at this URL, and I welcome your questions and further discussion, and thank you for your attention.
Do we have microphones? Right, so if anybody has a question, raise your hand. Please wait for the microphone.
Thank you for an excellent talk. I'm wondering if you could go over the futility analysis. I'm not familiar with that, and how that affected the results that were eventually put forward.
Sure. So the futility analysis, many large clinical trials, when they're designed and before they begin, there are planned out at specific points during the trial interim analyses, where an independent body, usually called a data monitoring committee or data safety monitoring board, they will take periodic looks at the data. And that might occur at the halfway point just once during the trial, or maybe at 1/3, 2/3. They're different depending on the size of the trial. It could occur at different time points. So for the 2 pivotal phase 3 trials for Aducanumab, there was a planned interim analysis to look at, do what's called a futility assessment, which is if the data at some point shows that it's unlikely that if you continue to completion, that you're not going to find any evidence of benefit in the drug you're testing, then you should just stop, because it's futile to continue, and it's probably unethical to continue to expose subjects, enroll subjects in the trial, and expose them to risk, if indeed you expect not to find any benefit for the experimental drug being tested. So that's what happened here. Now, a large number of subjects had already enrolled. The primary efficacy endpoint was to be assessed at, I think it was 18 months after beginning either the drug or placebo. And that was the point at which they were going to make the pre-planned assessment of whether the drug works. And so it was important to reach that point and have all your subjects get to there. But because they terminated the study, a significant number of subjects didn't get to the point where you're going to do your measurement of does this drug work. And so by doing that, trying to do sort of post-hoc analyses and draw conclusions is often very subject to bias because your study wasn't completed as intended. And so when you put this in the context of 22 other drugs targeting beta amyloid that didn't show benefit, it was highly likely that this small positive result that was very small in one dose in 2 trials was almost certainly a false positive result given the historical context of drugs targeting beta amyloid.
Why did they allow the futility analysis
Wait,
to?
you gotta have the mic.
I don't understand why the futility analysis was allowed to complete the study when the company wanted to go forward with it.
Yeah, I mean, so no more subjects were enrolled, but there were still subjects coming back for scheduled follow-up appointments, presumably. I mean, ultimately what they need to do is sort of stop the study and take people off, but they ended up getting some additional data. Maybe a few more patients reached the target endpoint of 18 months, and so you had a little bit more data. And so that was rolled into these post-hoc analyses that the company did in collaboration with the FDA.
But they
Oh, okay. Well, mine is sort of related. And I think your slide said, I mean, these futility studies were looking at the initial data on the primary efficacy endpoint. Was that a clinical benefit endpoint, or was that the accrual or the decrease in accrual of amyloid plaques? What were those studies considering their primary efficacy endpoint?
So the drug does reduce beta amyloid plaque in the brain, and that had been shown in the phase 1 studies. So no one's arguing that the drug doesn't reduce beta amyloid in the brain. The question is that meaningful? So the primary efficacy endpoint was not that. It was a composite measure of a standardized instrument for measuring cognition, memory, functional status that had a scale that ranged from 0 to 18. And again, no effect at all for real one at either dose. If anything, nominally, it was worse with the drug, very slightly. And then no effect at the low dose in study 302, very slight difference. The difference between the placebo group and the experimental group that got Aducanumab was 0.4 on an 18-point scale, where normally, published literature says a clinically significant difference would be a change of 2. So that's when I say it wasn't clinically meaningful. That's the reason I'm saying that.
Thank you.
So, yeah, sorry, we're dominating on this side. We'll spread the wealth in a minute. I'm wondering if part of this was just pressure to come up with some kind of new drug for Alzheimer's, since there's just so little out there. And I'm also wondering if this is part of a pattern, because I've read that the FDA has approved generics, for example, that should not have inspired a lot of confidence because they're under pressure to allow cheaper drugs to come to market. And the generics are not nearly as effective as the brand name drugs.
We all want a cure for Alzheimer's disease or a drug that significantly impacts progression of the disease. Family member, friend, or other significant other that's had the disease. It is a horrible disease. And so, yeah, there is a desperate need for treatments that work. But what we need is treatments that work. But did that influence the reviewers? It certainly may have. I can't speak for them. That may be something that the OIG will examine. What motivated you to pursue the pathway you did in reviewing and approving this drug. Generic drugs those are very different than new molecular entity drugs like we have here. I mean, for generics, the active ingredient is identical to a brand name reference product, and all you have to show is that basically achieve within limits the same drug levels when you take the generic version versus the brand name version. Those are pretty simple clinical trials. Obviously, there's a desire to get as many generics on the market now for brand name products that are no longer under patent or monopoly protections. You know, the American public is one of their main concerns is unaffordable drugs, rationing drugs because they can't fill their prescriptions because they can't pay the co-pays or the full cost depending upon whether they are insured. But so I think there's pressure on the FDA to do lots of things that extend beyond just this.
So I wanted to follow up on Sharona's question. My understanding historically is that a lot of the pressure to create the accelerated approval methods stemmed from the AIDS epidemic and the pressure that AIDS patients and their allies, if you will, put on the need to approve drugs better, faster, so forth. And what I haven't heard you mention is any efforts by patient groups, Alzheimer patients groups, in this controversy. And I'm wondering, did they play a role in this at all?
Sure, probably. At the FDA Advisory Committee meeting back in November of 2020, at least 2 representatives of the Alzheimer's Association spoke at that meeting and talked about the need for treatments for Alzheimer's disease and favored FDA approval of the drug. And it's clear that the FDA officials had meetings with the Alzheimer's Association. There were meetings that included the Alzheimer's Association, Biogen, and the agency. So there certainly was a push from at least from organizations that purport to represent the interests of Alzheimer's disease patients that pushed the agency as well. And you know, the FDA, this didn't happen in a vacuum. That's why Congress is partially responsible for why we're here. Congress wants the agency to be in partnership with the pharmaceutical industry. They've passed these laws with the lobbying of the pharmaceutical industry. So, you know, FDA is not the solely to blame here, but they are certainly the central player.
Hi, thank you for a really cool talk. I'm sure we're all concerned with the layperson's ability to have confidence in the government and with approval, FDA approval being something that they can rely on. So especially currently with coronavirus and vaccines also going through similar, maybe not entirely similar, but accelerated approval programs, and having personally faced people who are skeptics because of the fact that the FDA does have reason to, we have reason to not trust the FDA in certain regards. My question is, what other avenues can a layperson rely on to look for sort of external confirmation that some, like so let's say a drug is useful or not? Because I noticed that several physicians and healthcare providers condemned the use and announced that they weren't going to use it. Is that something that you think that a layperson could rely on, or perhaps other external agencies or independent groups that could review these things and give other people reliable answers?
Sure. So I mean, specific to Aducanumab, obviously there's just a huge amount of information out there. There's our work, there's lots of op-eds that were written by neurologists, other experts, advisory committee members, you know, saying why this drug shouldn't be approved, leading up to the approval decision. Certainly you're right that, you know, what played out here with Aducanumab and the very public controversy, probably for some people is causing them to doubt the FDA as a regulatory agency for all sorts of things, drugs, vaccines, which is unfortunate because in contrast to the data for Aducanumab, there's overwhelming data on the safety and effectiveness of the COVID-19 vaccines. There's just overwhelming data. That's not what we had here, but you know, people aren't going to be able to separate that out. Those who want, you know, who have concerns. You know, our group, we write independent reviews and have for years about drugs. We publish a newsletter called Worst Pills, Best Pills News. Sydney Wolf for several years, put out several editions of a book called Worst Pills, Best Pills, in which we sort of ourselves independently look at the clinical trial data that the FDA used to approve drugs and make recommendations about whether we think a drug should or should not be used. And if not, what are the alternatives available? So there are drugs that we label as do not use because they have unique risks and no unique benefits, and there's no reason to be using them. There are other drugs we label as limited use, where within the scope of the FDA-approved indication, it's reasonable for some people to use, but maybe not others. So we're one group that tries to give independent reviews of drugs. There are a few out there that do what we do.
So I'm not the best at math. That's why I'm in law school and not med school. But that 5-year renewal period is coming up, right? To your knowledge, are there any legislators that are taking up this issue in Congress, perhaps to refute renewing? I did not write down the acronym.
Reauthorize.
Reauthorize PDUFA.
Yep. So PDUFA and all the other user fee programs are here to stay. Congress loves them because they can get money from another source other than taxpayer dollars, and they can give, it doesn't contribute to the deficit spending. Pharmaceutical industry loves them too because in exchange for these fees, they got faster reviews and an easier pathway to approval of drugs. The FDA loves them. The huge number of staff are supported by these user fees. And so there's just, when the reauthorization comes up, it's always considered must-pass legislation. It will be passed, reauthorized in 2022. And so because it's always must-pass legislation, it's just an easy vehicle. When you have must-pass legislation, it's an easy vehicle for mischief, for lobbying to attach other things to that people want to push through because they know that thing is going to get pushed through. And it's easy to put on Christmas ornaments or decorations on the bill as it moves forward.
Question way over.
Hi, thank you for this talk. This is very interesting. My question is more about the financial impact of this medication. I don't know if you are able to speak to why it would cost $56,000 a year, but just looking at the population with Alzheimer's, 85% of them are Medicare eligible, and if it were to somehow be proven to be effective, would your organization still have reservations because of the cost benefit of analysis of the impact on the healthcare system?
Sure. So we have another group of public citizens called Access to Medicines, and their focus is the pricing of drugs, the monopoly pricing that makes drugs unaffordable, and we have that part of public citizen has pushed for reform. So if this drug was highly effective, we would not have opposed its approval. We would have endorsed its approval. But then our Access to Medicine team might have turned its focus to, is any drug, even if it's effective for Alzheimer's disease, should we be paying $56,000 per year for it? A cost that's probably not affordable to our healthcare system. And so, we have one of the pieces of legislation that's sort of stuck in Congress right now is giving the Medicare program the ability to negotiate pricing. This type of drug would be one thing subject to that type of provision if it ever got through Congress and was enacted.
Yeah, I have another question over here. Thank you so much for coming. This has been very interesting. I actually interned for Biogen over the summer, so it's kind of interesting seeing the other side of this. But I had a more specific question that was geared around your specific recommendations of how you think the FDA should move forward in consideration of these relationships. I think that there is really a role for things like surrogate endpoints and expedited approvals. There's been a longstanding history of good drugs benefiting early on the market and the patient population benefiting as a result. So more specifically, is your recommendation that we should remove or try to lobby for legislation like PDUFA to be removed, seeing that it kind of encourages that relationship? Or do you have another type of recommendation, and more specifically, what does that look like?
So on the issue sort of PDUFA globally, from its first introduction, pre-1992, our organization was totally opposed to that. We think the FDA should be funded with taxpayer dollars to avoid any quid pro quo from industry funding the agency. So that's sort of just a general thing. In terms of surrogate endpoints and the accelerated approval pathway, we're not saying throw that pathway out. We think that before you start making drug approval decisions based upon a surrogate endpoint, that surrogate endpoint should be validated through appropriate scientific studies that prove that it is predictive of important clinical outcomes. That's not the case here. FDA, in fact, has put out draft guidance, never finalized, that basically said before we're going to do accelerated approval on the basis of beta amyloid for a drug for Alzheimer's disease, we're going to require that that there's a valid endpoint that's been accepted by the medical community as being a good marker of that. So for heart disease, elevated blood pressure is a marker of bad outcomes: heart attacks, strokes, kidney disease. And so drugs that treat blood pressure and lower blood pressure, yeah, that's a reasonable surrogate marker for a drug that's going to have meaningful clinical outcome. But we don't have that validated marker here, that validated endpoint for Alzheimer's disease. One solution that I presented in my talk was sort of separate, in terms of preventing these types of collaborations that can undermine the integrity and objectivity of reviews. We understand there are going to have to be interactions between agency officials, agency reviewers, agency staff, and drug companies to help give them guidance on how to design studies, how to conduct them, how to analyze them. But we think, because of what we saw here in the Aducanumab case, there should be different people then that make the decisions, reviewing the application and deciding whether the evidence does show safety and efficacy, and that there should be a firewall separating those two. That's our solution to sort of culture that's sort of set now in stone, and we're not going to be able to eliminate. I'm not going to be able to eliminate interactions between agency officials and industry pre-submission of marketing applications.
Well, we're out of time. We're actually a little over time, so I want to thank Dr. Karam again for that.
Sure. Yeah.